Hi guys, my name is Sally Brockman. I'm the Community Outreach Specialist here at Memorial. We've got a presentation today, our first ever online only seminar with Dr. Higgins. He's going to talk to you guys a little bit about diabetic nerve damage and how to avoid it. We do have the comment section open. You are more than welcome to leave some questions and we'll ask him those at the end. In the meantime, please enjoy.
Thank you. Again, I'm Donald Higgins. I'm a board certified family physician. And I work as a wound care specialist as well from Lake Charles Memorial Hospital. Eager to talk about this subject, and the goal is to hopefully educate some folks on a very common condition and potentially series of conditions. And if you don't have this, maybe shed some light on something that a loved one or a family member may be dealing with. This is in no means an all-inclusive talk. But hopefully you get some good information, and it'll spark the opportunity to learn more and to have more of a discussion with your primary care physician and other healthcare specialists. So we'll start. As you can see, the title is "You've Got the Nerve." So we'll be talking about diabetic nerve damage. So got a list of a couple objectives here. The first few things that I want you to get out of this, or this is what I want you to get out of this. So some facts about diabetes first off. Then we'll talk about the definitions of diabetes and neuropathy. We'll explain how diabetes can lead to several complications, but we're gonna focus more on neuropathy, and then we'll talk about some evidence-based therapies to prevent complications from neuropathy, and then some other therapies that are available to treat neuropathy itself. So why do we want to talk about diabetes? Diabetes is a worldwide problem, and it is also a big problem in the United States. But we're based in Louisiana, and in Louisiana especially, it is an important topic to discuss because of how widespread it is. A few facts. Diabetes is among the leading causes of death in Louisiana. 1 in 8 adults have been diagnosed with diabetes. And our mortality rate in Louisiana is the 5th highest in the nation related to diabetes, with 27 diagnosed cases per 100,000 residents. There's interesting discussion on this because diabetes in and of itself usually does not cause death. It causes other things like heart disease, strokes, and even kidney disease. And so a lot of times I think that these numbers are actually underreported, and that's important to know. So we have a very important condition that lots of folks have, and we want to educate them more about it. So who's at risk? This is from the Louisiana Department of Health, and just boiled down very briefly, but as of now in the state of Louisiana, we have more females than males, more African Americans than Caucasians, and some other risk factors are actually low income and lower education or higher risk for developing diabetes in your lifetime. There's actually a really steep drop off in risk just from having completed high school. There's almost a 10% drop in risk. So I think it comes along with education in general, not just education in a structural sense, but just understanding the condition, understanding your risk factors, and also understanding how to treat it to try and avoid complications. So who should be paying attention? In a nutshell, everyone. As I said, 1 in 8 people have been diagnosed with this. And so if you have any number of family and friends, even if you don't know their diagnosis, you probably know somebody who's been touched by either diabetes or neuropathy or both. And if you haven't been diagnosed, some of us may become diagnosed later on. So the more information you know now, the better you can do to help take care of yourself and others down the line. So now we're going to meet a couple patients, and we're going to do this throughout the presentation. But our first one up is Mr. Bruce. So we're going to meet Bruce. Bear with me. Bruce is a 45-year-old black male who was recently diagnosed with diabetes after a visit to the emergency room. Bruce follows up with his primary care physician and asks, what exactly is diabetes and why am I on new medications? We do see this a lot. Sometimes people go in for other things and they end up with a diagnosis of diabetes. It catches them off guard. And that's where hopefully us primary care physicians can help to demystify and educate our patients and help them to live long, healthy lives. So going forward, what is diabetes? Okay, so diabetes mellitus is what we're talking about. And this refers to a group of diseases that affect how your body uses blood sugar, or glucose, which is our technical term. Now, glucose is very vital for as a source of energy for our bodies and our organs. So it's not something you want to eliminate, but it is something we want to control. It actually typically has two types, type 1 and type 2, but recently there has been description of another group of people that have conditions that affect blood sugar called prediabetes. Some of you have probably heard that term or have had that term used with your doctor. Prediabetes means that you've had some high blood sugar, higher than normal, but you don't meet the criteria for diabetes, and that's typically a type 2. Now, type 1 diabetics usually present earlier on in their life, and typically their pancreas does not produce enough insulin for their body to take in the sugar that they eat. And so that raises your blood sugar, and when the blood sugar is high, it affects the tissues in the body. Type 2 diabetes is typically a later onset condition, and it's usually not because your body can't produce insulin, it's because your body can't use its insulin properly. So you have something called insulin resistance. And insulin resistance keeps your sugar high and causes those same conditions to happen. Prediabetes usually has some insulin resistance, but a lot of times, again, it's a milder case, your levels aren't as high, and there haven't been a lot of, hopefully, disease process going on in the body. So here's some signs and symptoms of what diabetes, and sometimes even prediabetes, can present as. Increased thirst, and that's usually because your body is trying to get rid of extra sugar and trying to flush it out. So we want to drink more water, which then makes us urinate more. So you may find that you're going to the bathroom more often. You might find yourself more hungry, because that's something else that I did not say, but if your blood sugar is high, your tissues and your organs aren't using that energy, so they're still hungry. So even though you have a lot of blood sugar and you should have a lot of energy in your cells, your body's not able to utilize it properly, so you can see a lot of hunger. You can see unexplained weight loss because of this, but on the other side, you actually can also see weight gain, but that typically is not unexplained. That typically goes along with increased diet or increased food intake. We can see a lot of tiredness and fatigue. You just kind of run down. Again, your body has blood sugar, but you're not able to use it properly in diabetes. You can become irritable because of that, because our brain's number one source of energy is actually glucose. So if it's not getting enough glucose, you're going to be a little irritable. You can also have blurred vision, and that's really important for later on because diabetes can affect the eyes both acutely or short term and long term. You can start having slow healing sores, and that's important with our neuropathy talk later on as well. Some of them you feel, some of them you don't. And frequent infections such as oral infections or urinary tract infections, and for women, sometimes you can have vaginal infections as well. So all these symptoms can sometimes clue us in that there may be something going on in your body that's akin to diabetes. So how do you test it? So if you go to your primary care physician or the providers, they will definitely start asking questions about your symptoms. So in medicine, we refer to them as symptoms. That may not mean much to you, but that's basically what kind of problems you're experiencing. We'll perform a physical examination to see if we can find any physical findings, but the bread and butter of this is really going to be blood and urine tests. So some things that they're going to be looking for are your fasting blood glucose. Again, that's your blood sugar level when you've not been eating. This is typically the one that people really worry about, and that's the first one that usually clues us in quickly that somebody has something going on with their blood sugar. But it's not the only thing that can clue us in, especially since some folks actually can fast really well before their labs, and get a normal blood sugar, we also have found another test called the hemoglobin A1C. So the A1C is something that your doctor's probably tested for you at some point in the last year or so if you have any of these conditions, and it's an average blood sugar over the last 3 months. So even if you get a good normal fasting blood sugar, you may still have a blood sugar that's higher throughout the day and could still be causing damage to your tissue. So it's important that we also know the fasting blood level and the A1C to help us figure out how much control you may have, or if you have diabetes at all, or prediabetes. Urine tests can show increased sugar because, again, the urine is one way that we get rid of excess sugar. And because it has excess sugar, it can lead to urinary tract infections. But our bread and butter is really the fasting blood sugar and A1C to know how to diagnose it. So a list of common medications. The reason I put this in here is a lot of people are on medications. They may not know that they are for blood sugar. This is not an all-inclusive list, but if some of these medications look and sound familiar, you're probably taking them for blood sugar purposes. Metformin is the most common one. If you've never taken it, somebody you know may have taken metformin. There's several different types of insulins. They go by different brand names: Lantus, Toujeo, Basaglar, Humalog, Humulin, Novolog, Novolin. But those are basically insulin that we can give you if your body's not processing enough, or if you need more insulin to help you get that sugar down and into those tissues. Trulicity, Bydureon, and Victoza are newer agents that are injected, but they are not actually insulins. It's kind of confusing for some folks. But if you're on any of these medications, I want you to make sure you know why you're on them. And if you don't know now, it'd be a good thing to discuss with your doctor to make sure that you understand why you're on them and everyone's on the same page. Oral tablets, glipizide or glyburide, have also been around. There's newer agents that are tablets like Farxiga, Jardiance, Saglatro that help us get more sugar out through our urine. And then some other medications down at the bottom, Januvia, Tridenta, and Onglyza, which can help your body and your pancreas use its own insulin a little better. But again, if any of these medications look familiar and you're not sure why you're taking them, please talk with your primary care physician or a diabetes specialist and make sure that you understand why you're taking them and why you need to. Okay? So now we're going to meet Miss Claudia. Claudia is a 50-year-old black woman with type 2 diabetes. She was recently placed on a new medication for burning sensations in her feet by a local urgent care. Claudia immediately followed up with a primary care physician and asked, "What is diabetic nerve pain?" Good question. So what is neuropathy? Neuropathy is just a medical term for nerve damage. It sometimes can be confusing, and we have different terms to describe it, like polyneuropathy and things, and that just means multiple nerves, or mononeuropathy, which means a single nerve. But neuropathy is just a term for nerve damage, okay? It can be symptomatic or asymptomatic, meaning you can have some problems or you may not experience any. It's a common finding in diabetics, but it's not the only condition that has neuropathy. Other conditions, and this is again not all inclusive, but other conditions that have neuropathy, or there's an alcoholic neuropathy, and there's actually other B vitamin deficiencies that can cause neuropathy in the body. Now these are typically somewhat reversible and can be treated by supplementing the nutrients that have been lost. But there are several different types of neuropathy, and again, I want to focus on diabetic and kind of that for today. It is estimated that 1 in 4 people that have diabetes have neuropathy. So again, if you know somebody who has diabetes, you very likely know somebody who also has neuropathy. So going more into that, signs and symptoms of diabetic neuropathy. So we have 2 different types of nerve fibers that help us feel our bodies and know what we're contacting in the environment. We have small fibers, which actually help us with temperature sensation and sensation of touch and fine motor touch and things like, fine sensation, sensory touch and things like that. So when you have problems with this, you have typically either numbness or burning pain, or sometimes both. You don't know how hot or cold something is, so you can't quite gauge if you should be pulling away from something that may be too cold or too hot. And then there's another thing in the middle that says autonomic dysfunction. That's another type of nerve that actually does not help us feel our bodies out in space. It actually helps us regulate things inside our body. And that typically does not cause a lot of pain directly. Those large fibers are the other type of nerve that we use to feel things out in the world. It helps us with proprioception, which means you can tell where you're at in space. It kind of helps us with balance, okay? Vibratory sensation and muscle weakness and reflex issues are our next thing. So if you have large fiber issues, a lot of times these people are more prone to falls or putting more pressure on their feet and other extremities than they should, and you sometimes see tissue damage because of that. And again, yes, diabetes and diabetic neuropathy can affect other parts of the body. As I said before, diabetes can affect all tissues in the body, but when it comes from a nerve perspective, you may have several symptoms that nobody really attributes to diabetes. You may have dizziness or lightheadedness, especially when you change positions. So if you stand up too soon, you may feel lightheaded or dizzy, and that's something from postural hypotension, and that's actually from our nerves not being able to regulate our blood pressure changes when we change position. Intestinal issues can come up with either constipation or diarrhea, and sometimes a combination of the two. And also you can have, on top of that, nausea, vomiting, and sometimes poor digestion. You can get the feeling that you can't eat as much as you should. Food just sits on your stomach, and that's from something where the nerves get affected in the stomach, and the food actually does sit there. It's called gastroparesis. An important aspect to know about these things is that all of these are caused by nerve damage. Once these things are manifested, there's likely a level of irreversible damage to the tissues. So that's why it's really important to try and prevent as much as possible. And even if you do have these conditions, to try and keep things under control so you prevent worsening of symptoms. So just to kind of drive home that again, what are we seeing with this neuropathy? So in a typical thing that we think about is problems with the feet and ankles. So if you get decreased vibratory sensation or proprioception, you got poor balance, you can't feel your feet touching the ground, and reduced ankle reflexes and sometimes ankle strength, you're more prone to, again, falls, and you're more prone to banging into things. If you knocked your toe against the wall, you may not feel it. And if you do that over time, you may really develop some damage before you ever notice that anything is wrong. So again, if you got these decreased sensations, it means you can't feel as much as you should, and you can't feel where you're going without looking. And an important thing is that up to 50% of patients with neuropathy may not have any symptoms. So they may have some numbness, but it doesn't really affect them, or they don't think it affects them. And sometimes it's tough to figure out who has it until they already manifest a wound or knock their toe against something, and we see a broken toe with no pain. So some complications of these things. So if those peripheral nerves, so those nerves that help us feel our body out in the world, are affected, again, you have the weakness in the reflexes and strength, decreased balance or proprioception. You can have numbness and pain, and you can have numbness over the feet, and if you have numbness over the feet, that's when wounds are more likely. If you have autonomic or internal nerves affected, those things can be painless. And one thing I want to make sure I've talked about is the pain. Okay, neuropathy has pain. I haven't said what it felt like, and it changes from person to person. Sometimes people feel a burning sensation. It feels like things are on fire. Sometimes people feel a pins and needles sensation, or even like some people describe it as ants crawling on the skin, so something akin to your foot falling asleep or arm falling asleep if you've laid on it too long. Sometimes you can have a shock or electric type sensation, and sometimes people just have a real tough time trying to describe it and just describe it as pain. So how do we treat neuropathy? So our goals are the top two points. So we want to limit pain. Okay, if you already have numbness, we can't really treat numbness. We can't reverse numbness a lot of times unless there may be a vitamin deficiency or something else that we can treat. So our main goal is to keep people comfortable and eliminate that pain. That way the sensation that they do have can kind of shine through and they can feel a little bit better. Literally feel better, feel their feet more. We also want to protect against increased pressure, because again, if you can't feel, you can't protect yourself from laying on a certain area too long or standing on an area too long. So our typical ways to treat the pain are actually medications, and there's several different types of medications, but the most common and first line medications are what I've listed here. And some of them are old anticonvulsants. So they're old anti-seizure medications. And you may say, why am I taking a seizure med? Well, that's because they're working on nerves and how the nerves transmit. And nerves transmit pain. So if you're able to slow down the transmittance of these signals, you slow down the pain sensation. So Lyrica or pregabalin and Neurontin or gabapentin are very common medications that we use. Another important thing to know is that side effects of these medications can be drowsiness a lot of times. So some people tend to have a side effect with these medications, and if you know what you're looking for and you're communicating with your doctor, you can work out the kinks on a proper regimen for you to increase your benefits and decrease your risk factors. Older antidepressants like amitriptyline or brand name of Elavil, which a lot of times these days is used to help people with sleep for the same reason. It helps modulate those nerves and how they transmit pain, and that can help us again with pain. Newer agents like Cymbalta or duloxetine have really been studied and shown to decrease the nerve stimulation or sensation, and it helps us again with those neuropathic type pains, those burning pains, pins and needles, ant sensation, shock type pains. Not so much arthritis type pains, which are something else that usually are associated with joints, overuse, or inflammation, and a lot of times feel more like an achiness type of pain or a pressure type of pain. This is specifically with neuropathic type pain. Other things that we can use and have variable benefit are lidocaine patches or capsaicin cream, which are topical. And I've even seen mention of isosorbide dinitrate, which is kind of like a nitroglycerin equivalent, but in a spray form to spray on feet at night. That has been shown to help with some of the sensation that keeps people up. One option that is not a medication, but is sometimes offered from doctors who are properly trained, and a lot of times these end up being neurologists or nerve specialists, but transcutaneous nerve stimulation, which is a big word for basically we stimulate your nerves across the skin without actually going too invasively. And then down at the bottom again, only if you're vitamin deficient have these vitamin supplementations been shown to work, okay? So now we're going to meet Mr. Darryl. Darryl is a 60-year-old male who struggles with diabetes and neuropathy for the past 2 years. His wife noticed a new wound to his left foot a few days ago after routine yard work. On examination with his primary care physician, Darryl states, "I didn't feel anything when I hit my foot against the porch." Again, this is what we talked about. You may not notice it, but somebody else may notice an issue for you unless you're actually checking your feet out or your extremities out. So Mr. Darryl probably has the critical triad. So we got some nice little diagrams and images that show us in the top left corner. This is typically the type of sensation that can be associated with nerve pain. So you have a peripheral sensory neuropathy. You can have over in the top right corner some kind of trauma, so some kind of injury that caused or trauma or something that caused an injury to the tissues. And that's really needed because before you have an ulcer, you got to have something that's going to cause that force. And then deformity. Deformity can sometimes be something that's obvious. You might have a hammer toe or a big joint deformity or a callus or corn on your foot, or you may have a more subtle change in the joint of the feet, of the arms, or things like that may not be as readily seen. But there has to be some kind of, typically a combination of these to start having foot ulcers or diabetic foot ulcers. Now, again, you can have ulcers and other things that happen because of neuropathy, as we talked about with the changes in postural hypertension and having nausea and all these other things if you have a neuropathy diagnosis. But I wanted to specifically talk about diabetic foot ulcers because that's usually one of those things that people are more commonly aware of, and they know they want to try and prevent it because we've all heard of somebody who has a wound to their foot that's a diabetic, and they're always concerned about advanced or aggressive treatments. So roughly 1 in 3 people with diabetes will have a foot ulcer at some point in their life. That's big. And roughly 2/3 of all non-traumatic amputations, so not being in a car accident, not having a big injury, or because of diabetic foot ulcers. And in those people with foot ulcers, 80% of them have neuropathy. So about 50% have neuropathy alone and no other issue underlying, but then 30% of those people have neuropathy and peripheral artery disease. So that means blocked arteries in their feet or their legs. We always worry about blocked arteries in the heart, and that's something that everyone's commonly aware of. But if you have blocked arteries in the heart, you can be at increased risk of blocked arteries in the legs and the arms and other places, and they can do some significant damage. What happens there is our bodies aren't able to get the oxygen and blood down to the tissues that need it, so you're not able to use your immune system to fight off infections. You're not able to use the blood flow to heal up wounds, and so instead of healing, things kind of just get worse and worse. So it's real important to treat diabetes, not only to prevent neuropathy, but to prevent the blocked arteries or partially blocked arteries that can affect healing and other things as well. Another thing that I want to say about the peripheral artery disease is that in diabetics specifically, there's a different type of blockage that affects these arteries, and it's very extensive. So a lot of times we hear about people getting blocked artery and they go get a stent and it opens it up and things are a lot better. Sometimes it's not possible in people with diabetes because it's such an extensive disease by the time we get symptoms that's really tough to treat it, and that ends up leading to those amputations. So really important, going back to those early slides, to understand diabetes and to take care of it early on. So this is a busy slide, but these are kind of the do's and don'ts of care for your feet, and that's care for any extremity if you have neuropathy. You want to look at your feet. If you can't look at your feet because you don't have good vision, you want someone else to look at your feet. Okay, that should be a daily thing so they can check for cracks, redness, bumps, lumps, any signs of infection, blisters, calluses forming, which can show you where things are rubbing too much, and even nail problems, because all these things start off real small, but by the time we find them, a lot of times people are worried because they've become bigger and deeper issues than they have been in the past. You want to regularly moisturize your skin so it doesn't get dry and cracked, and you want to have periodic foot exams, either with your primary care physician, your diabetes specialist, or even a foot specialist like a podiatrist to help prevent things before they become an issue. Things you don't want to do, especially if you have neuropathy, you may not feel temperature the right way, so you don't want to do any soaking of your feet without properly checking temperature or recommendations from your care provider, because you may end up trying to help treat your feet and clean your feet, and you might end up scalding them with water that's too hot, and I have seen that before. You don't want to try and remove any of those thickened corns or calluses either on your own. You want to help make sure that somebody's doing it properly so that they don't go too deep and open up an opportunity for an infection to get in. So if you got something, please get to a specialist so they can help take care of it properly and efficiently. Okay? Another thing that some people don't think about, check those shoes at home, okay? You may have a rock or something hard in there that's sitting in there. You won't feel it. So check them out, turn them over, dump it out, make sure that everything is as it's supposed to be, because it's not always that you bang your foot against a wall and cause an injury. Sometimes it's just an ill-fitting shoe that you don't notice until it's months down the road. And then we want to maintain healthy blood sugar levels and other preventative care. Down at the bottom, the Charcot foot is one of those deformities that I was talking about. This is one that's more common to diabetics, and it's a chronic progressive thing that happens because of weakening of bones over time. So once this happens, it is tough to treat, but a lot of times we end up getting folks to wound care or podiatry specialists to help out. So all is not lost. So why do we treat these diabetic foot ulcers? We want to heal them quickly. Time is tissue when it comes to a foot ulcer. So we want to also avoid further loss of tissue, because if you have a break in the skin, you may have infection, you may have poor blood flow that will affect us in our ability to heal these things up. And sometimes we have to be aggressive and take more tissue away so that the good stuff is still there and can heal up more rapidly. So our goal is to save tissue, to heal them up quickly so you have your good protective barrier in your skin to keep you from getting things like infections or dirt and things like that into your deep tissues. And also to avoid amputation if we can. Okay, everyone wants to avoid amputation, so that's why we treat these things. So how do we treat it? It's a busy slide, but we do use a multidisciplinary approach, which means we don't just slap a bandage on the wound and just forget about it. We want to check those bandages, make sure that they're helping heal it. We want to make sure that all your risk factors, like diabetes, are being controlled so that your wounds can properly heal. We want to check your blood flow and things like that to make sure that you're getting the oxygen and tissue and nutrients down there that you need to heal it up. We remove any calluses or ingrowing nails because these could put pressure on areas that could cause new wounds. Take away all the dead necrotic tissue, and that's what necrotic means, is just dead, because that'll slow up our healing process. We also want to treat for infections if they are there, so we always want to check for them and treat them if needed. We want to, this is a big one, offload the area of the wound. Keep pressure from building up so that your body can do what it's designed to do and heal itself. And how do we do that? We wear boots, supportive shoes, casts, and other durable medical equipment. And at the bottom, I got it at the bottom for a reason. This is hyperbaric oxygen therapy. This is for special cases that are difficult to heal and or have infections that are too deep for us to treat with antibiotics alone. But it is something that we can use, okay? So this is just a slide to show you what some of that equipment looks like. So in the middle, people don't think about this very much, but crutches are a great way to offload an area that might have a wound. As long as we're aware that we might be putting pressure somewhere else, crutches can help. A nice, beautiful orthotic shoe, so or a diabetic shoe, sometimes people call them, can help us offload these areas. In the top left, that is a total contact cast. It's a very bulky and heavy device that person cannot take off on their own, but it's been very good for keeping people that can't or have trouble staying off of their feet, but really want to stay active and need to stay active. We can offload that pressure so that foot is essentially floating around with no pressure on it at all, and you can still get around and walk. Down at the bottom left is a walking boot. That's a similar device, but that's something that you can take on and off. Up in the top left is a knee scooter, which sometimes is a lot more bulky, a lot more difficult to get from point A to point B, but is an acceptable way to offload an area that might have a wound. And then down in the bottom right is what we call an Una boot, and that's something that we use to help with compression, to keep an area from swelling, keep that area and that wound covered, and help it to heal up properly. So just a little quick hits, kind of get you able to see what you might be using if you had one of these ulcers. Now we got one more person to meet. We have to meet Ellen. Ellen is a 48-year-old female who is an established patient of a wound care clinic, and she comes in for weekly debridement visits for her slow healing right foot diabetic ulcer. Debridement just means to basically to scrape away or to remove dead tissue, okay? And that's typically dead or necrotic or infected tissue. So the bad stuff, take away so that the good stuff can stay. Upon examination by the wound care specialist, Ellen is considered for hyperbaric therapy. Ellen then asks, what exactly is hyperbaric therapy and how will it help? So again, this is more related to those special cases, but I did want to at least open the door and let people see and answer a few questions about hyperbarics, what it is, and that way it kind of demystifies the whole process and you know what it is so you don't get too scared about it. Hyperbarics was historically used as a treatment for decompression sickness of deep sea divers, or something called the bends. It had to do with oxygen and or gases coming out of the tissues and causing a lot of injuries and issues with breathing. We started using that then, but now it's used in medicine for several different uses, including foot ulcers, treatment, and trying to heal them up properly. So hyperbaric oxygen uses pure oxygen and increased barometric pressure to simulate what we call a dive. It increases oxygen content in the blood and the wounds, and it also stimulates enzymes and growth factors in the wounds, and it stimulates your immune system to help fight off deep tissue infections and help improve wound healing. So it's important that this is not just putting oxygen on a wound, it's not airing it out, it's using your body and stimulating your body to heal it from the outside in and the inside out. There's several types of chambers, including a single-person chamber and a multi-person chamber. Multi-person chambers are typically a lot bigger. They may even be room-sized, and they have your caregivers and your patient in there at the same time and getting pressurized so they can do antibiotic treatments or whatever they might need and get their treatment while they're getting other therapies. In our outpatient wound care center, we have 2 single-person chambers, and that's what we kind of have behind me now. And as you can see, it is a tube, a large tube that somebody would sit on a bed or lay on a bed and go in and receive their therapy. It's completely glassed in, so a lot of people worry about hyperbarics actually causing issues with claustrophobia, which is a real thing. But you're very aware of your surroundings. You're not locked in kind of like what you would be in an MRI tube. You can sit and relax and watch TV, and we have those set up on top. And we always have an attendant with you sitting in between both of our chambers, so you're never alone, and you can always see what's going on around you. A lot of times that helps with a lot of anxiety if somebody were to go with hyperbarics in their therapy. Sometimes just seeing things like this can help people out and to help understand what they might be going into and what maybe some of their family members might be going through with their treatment. It is kind of a time-intensive treatment, and definitely does require commitment. Usually we do 5 treatments a week, and they take a couple hours at a time. So if you're going into this, it's not something we take lightly. It's not something we just put everyone into to try and heal up wounds. But this is something that we have been able to use for difficult to heal wounds, and really cut down on our time and energy, and in some cases save people's extremities from having to undergo amputation. So again, this is our single person chamber, completely glassed in. We'd slide you in there and let the oxygen stimulate your body to heal itself. So the next question is hyperbaric treatment for me? So to answer this is a complicated answer because it's not a one-size-fits-all. So I'd urge you, if you're concerned about something like this, make sure you're talking to your primary care provider, not just about the therapy that you might be interested in, but why you want it. You know, if it's because you have a wound, then say, you know, it's because I have a wound, I'm concerned that I might be a candidate for hyperbarics. If it's for another reason, and there are other indications, one of them being people who have had radiation treatment for cancers and have issues with bleeding in their bladders can benefit from treatment. There's several treatments, but sometimes you don't want to, if you want to ask about hyperbarics, which I urge you to if you're concerned about it, especially for foot ulcers, make sure you're talking about why you're concerned and why you want to think about that therapy, because that may help you and your doctor come to a better decision on this. So in a summary, you know, for diabetics and pre-diabetics, please follow up with your primary care physician regularly and have some of those labs that I talked about checked, and make sure that your therapy is doing well. Make sure you talk with them about any issues with your management and your medications. If you're having side effects, you're not feeling good, be open about it, because if you're open about these symptoms, they can a lot of times be mitigated. Make sure you understand kind of the dietary regimen, and if you're not sure, please talk with your primary physician more about how to properly change your diet or adjust your diet to improve your diabetic control. And please follow up for proper screening purposes. Eyes and feet and kidneys and all this, we want to make sure they're healthy. long term. For patients with neuropathy, please, again, be open with your primary care physician about new symptoms, changes in sensation, whether it's numbness or new burning sensations. Even if they're mild and you're not ready to start any kind of pharmacological therapy or medication therapy, make sure they know what's going on. And if you have any reactions to medications, be open with that. And also check your feet or check any areas where you do have numbness on a daily basis, or have somebody check them for you. Okay, and again, take all medications regularly, and again, talk with your provider if you're having issues. All right, now I guess we've come to the point where we can take some questions.
Yeah. We got a couple questions here. The first one is, can regular exercise keep diabetic ulcers from forming? If so, what is the best form of exercise?
Good questions. So regular exercise is always a very good way to prevent complications from diabetes, and sometimes from neuropathy as well. I can't necessarily say that if it's non-diabetic neuropathy that it will help prevent it or improve it, but what exercise does do is it improves our blood flow to several parts of the body, our anaerobic and aerobic endurance, and a lot of times that improvement in oxygenation actually helps us to either decrease the sensation of pain when it comes to neuropathy and decrease risk of things forming in diabetes like ulcers. So it's always recommended. The best form of exercise is always going to be what works best for the patient. So if you like running, you should, and you're safe to run and you've talked to your physician, running is great. If you hate running, it might not be the best one for you. So it's always tailored to the patient, and please, also consult your physician before changing regimens.
Okay, we've also got, can diabetes be cured, or is a diabetic always a diabetic?
That's also a very good question. So in a nutshell, once we kind of diagnose someone with diabetes, typically, and this is something I did not get into because we were kind of focusing on neuropathy, but when you're diagnosed with diabetes, there's typically already a irreversible loss of function in the pancreas and how you process sugar. So metabolically, diabetes is typically forever. However, it does not mean you have to be on all medications forever. If depending on the follow-up care, the dietary regimen, and your response to the dietary regimen and exercise, potentially weight loss if available, you can stave off or reverse medication regimens, but the underlying diagnosis is typically there because there have been metabolic things that are happening in the body that are irreversible to a point.
Another question is, I've heard that a sweet breath odor is a sign of diabetes. Is this true?
So if you have a sweet breath odor, yes, it can be a sign. So that sometimes is a sign of acetone in the system, and that's sometimes what we call a sign of diabetic ketoacidosis. Ketoacidosis may sound familiar from ketogenic diet that a lot of people are familiar with and are using, and that is something that can signal that there may be issues. So if you are a diabetic and you have noticed that smell, or somebody else knows that smell, you definitely need to be checked out, or at least check your blood sugar to make sure where you're running, because it could be an issue.
Okay. And then the last question we have is, during this virus, we've heard that people on metformin need to make sure they watch their kidneys and liver. Is that accurate, and why?
So that's another great question. So throughout this COVID-19, I'll say, situation, there's been a lot of information coming out. And especially before things got really intense in America, there were some reports that COVID-19 related illnesses can affect the kidneys, especially for people that are on certain medications that are tough on the kidneys. Now, metformin is one that we always are aware of, especially with someone's kidney function, and we don't want to use it in people that have impaired kidney function or the kidney function worsens to a point. So it is something that we always want to be aware of. Another one is anti-inflammatory medications. It does not mean we cannot use those medications if need be. It means that we have to be aware especially with people that are having severe symptoms from this virus, that we're very aware of the medication that they're taking and the continuation of their kidney function. A lot of times, though, what people are worried about is being on these medications and then having to get other therapies, which are also tough on the kidney. So if you're taking a big ton of antibiotics because you're in the hospital and you're already on a metformin regimen, that may be somebody who's at more risk of having issues with their kidneys. But in and of itself, nothing going on now means that we have to stop medications if you're on them now and you're taking them safely. And I would recommend that you continue that until you've talked with your primary care physician to manage that properly.
Okay. All right. Well, that's it. Thank you so much, Dr. Higgins, and everybody feel free to comment if you have any other questions, and we'll try and answer them in due course.
Excellent. Well, just right before we go, I just wanted to kind of let you see the outside of our wound care center here at Lake Charles Memorial. Here's a contact information, address, and phone number where we operate. If you're concerned about something not healing up on your body, I urge you to give us a call and see what we might need to be evaluated. This is a picture of me in the other office where I work most days of the week in a primary care clinic. Our address and phone number as well for anyone who may not have a primary care physician. Otherwise, thank you for your time, and I hope everyone has a great weekend and a great day.